Hi, my name is Neil Anglam, consultant cardiologist, and I'm going to talk to you about angina. I've done a previous video about the assessment of patients with chest pain, so if you click the link above, you should get to that video, but just now I'm going to talk specifically about angina pain. So, angina pain is a symptom that's described as a chest tightness across the chest. That's the first thing. Secondly, it's usually precipitated by exertion and relieved by rest. And thirdly, it can be relieved by GTN spray. Angina can be broken down to typical angina, atypical angina, and non-anginal chest pain. So typical angina usually has all those three features of chest tightness, on exertion, relieved by rest, and then also relieved by GTN spray. If it's atypical angina, it's usually two out of those three features, and if it's non-anginal chest pain, it's either one or none of the features I've just described. So when seeing somebody with chest pain, you also want to find out their cardiac risk factors. The top cardiac risk factors include a family history of ischemic heart disease, whether they smoke, are they diabetic, do they have a history of high blood pressure or a history of dyslipidemia. It's obviously very useful to also know if they have a previous history of cardiac disease, as that puts angina pain quite high up there in your differential diagnosis with somebody who presents with chest pain. And it'd be unlikely to be angina pain if it's sort of a continuous pain, a pain that's been there all day, or a pain that's sort of worse on movement, worse on inspiration. That's not really typical of angina. It's also unlikely to be angina if it's associated with other symptoms like dizziness, tingling, difficulty swallowing, or palpitation. To investigate the angina, there's a number of investigations we do for patients that present with angina-type chest pain. The first would be a 12-lead ECG. A 12-lead ECG may be normal, or it may show some subtle changes of cardiac ischemia, such as T-wave changes or ST depression. However, if we are suspecting somebody with angina-type chest pain, a very useful investigation is a CT coronary angiogram. A CT coronary angiogram is a non-invasive test. It does have radiation, but it's very low risk, and that's very good for picking up lesions within the coronary arteries. It's actually extremely useful in ruling out coronary artery disease. Another useful non-invasive test for cardiac ischemia is a myocardial perfusion scan. This involves using a radionuclide tracer, which is injected to the patient, and then the heart is stressed, usually with a inotrope or with exercise, in order to increase the workload of the heart. When the workload increases, this tracer goes to the cardiac myocardium and is picked up on a scan. If there is no increase in tracer in the cardiac myocardium under stress, then this area may have reduced perfusion and therefore could be the cause of the angina. Another non-invasive test is a stress echocardiogram, and again the heart is stressed using an inotrope such as dobutamine, and an echocardiogram is performed. If there's reduced blood supply to areas of the heart which may be causing the angina pain, then you may get regional wall motion abnormalities on the echocardiogram. Another non-invasive test is an exercise stress test or a treadmill test. This has kind of not been in favour really recently, especially in the NICE guidelines. The NICE guidelines in the UK suggest that we should not be using an exercise tolerance test to diagnose angina in patients not known to have coronary artery disease. So, I mean, if a patient is known to have heart disease and they've been treated in the past, but now they're getting their what sounds like angina pain back, in order to test how significant their angina is, they can be put on a exercise treadmill test. And what this involves is somebody going on a treadmill, being wired up to an ECG, and then being told to exercise. This is usually something called the Bruce protocol, where the exercise increases over every 3 minutes. The treadmill gets faster and steeper, and this sort of stresses the heart out, and you may see ECG changes if there's cardiac ischemia. The ECG changes we look for on exertion is ST depression or any T-wave changes. We also check the blood pressure, make sure there's a good blood pressure response to exercise. But like I said, the NICE guidelines suggest this test should only be done on patients with known coronary artery disease. And it's a good way of risk stratifying as well, because if they manage to do 12 minutes of the Bruce protocol until they get angina pain or ECG changes, then that's actually quite a good prognostic factor, as they've done quite a lot on the treadmill. But however, if they start getting chest pain and ECG changes at sort of 2 to 3 minutes, this is quite a poor prognostic factor, as they've not done very much on the treadmill. And finally, we also have the diagnostic coronary angiogram. This is really the end-of-line investigation for angina. As mentioned earlier, we do have the CT coronary angiogram, which is non-invasive and therefore safer. A diagnostic coronary angiogram is an invasive procedure, usually done through the right radial artery or the right femoral artery. It's done under the local anesthetic with sometimes some sedation, and this will directly visualize under x-rays the coronary anatomy. A diagnostic coronary angiogram does have risks to it, as it's an invasive procedure. Therefore, that's why it's not a first-line investigation for angina. The risks include a heart attack, stroke, or death, and we quote usually around a 1 in 1,000 risk of complications. So now, if we have a patient with cardiac sounding chest pain on exertion, so chest tightness on exertion relieved by rest or with GTN spray, that kind of gives us a strong indication that this patient could have angina. You may want to do a diagnostic test such as CT coronary angiogram to assess their coronary arteries to confirm that there is coronary artery disease. However, once we have a patient with angina, how do we manage these patients? But first of all, we'd like to address any cardiac risk factors as mentioned earlier. That includes managing their high blood pressure, dyslipidemia, diabetes control. If they smoke, we advise them to stop smoking, and then advise a general healthy diet and exercise. Then from a medical management perspective, we would offer medication for secondary prevention. That's usually an antiplatelet such as aspirin or clopidogrel, and then lipid modifying agent. Regardless of what their cholesterol is, we would offer them a statin, and my current practice is to offer atorvastatin 40 milligrams daily. So now to treat angina itself, the reason that the reason that a patient experiences angina symptoms is because there's not enough oxygenated blood flow gets into the cardiac muscle. So we would manage stable angina medically in the first instance, and the first medication all patients would receive would a GTN spray to use as required. A GTN spray will cause vasodilation of the peripheral and coronary arteries to improve blood flow to the heart. However, if we think about the other anti-anginal medications that are available, there are a number available, and they all work differently in order to improve the angina symptoms. So to improve angina symptoms, we want to increase, there's different things we can do. We want to either increase the blood flow to the heart muscle or decrease the amount of oxygen the cardiac muscle is using. To increase blood flow to the coronary arteries, we can decrease the heart rate, and what that does is it prolongs the time in diastole, and diastole is the time in which the coronary arteries fill. The other way we can improve blood flow to the heart muscle is to give medications that dilate the coronary arteries. In order to reduce the amount of myocardial work, we can again give medications to reduce the heart rate, reduce the contractility, reduce the preload, and reduce the afterload of the heart. They all work to reduce the work of the heart. So I've already mentioned the use of the GTN spray causing vasodilation, but from a regular anti-anginal medication perspective, the first line medication we would prescribe is a beta blocker, and my own practice I would use bisoprolol. This will reduce the contractility of the heart and also reduce the heart rate. If a patient is on bisoprolol and still continues to experience angina pain, the next anti-anginal medication we would add to the bisoprolol would be a dihydropyridine calcium channel blocker such as amlodipine. This causes vasodilation and therefore increasing blood flow to the heart muscle. If a patient cannot take a beta blocker, for example, they have asthma, then you could start them on a dihydropyridine calcium channel blocker such as verapamil or diltiazem as a first-line anti-anginal. So other second-line anti-anginal medications that can be used if a patient's already on a beta blocker or calcium channel blocker include isosorbide mononitrate, which is a vasodilator, nicorandil, again, it's a potassium channel opener, which acts as a vasodilator, and another agent for patients who can't take beta blockers is ivabradine. That works on the IF channel, and that purely reduces the heart rate. One of the newer anti-anginal medications around is a medication called ronolazine. This affects the sodium channels in the myocardium and results in improvement of the myocardial relaxation and coronary blood flow. However, if a patient is stable on one anti-anginal medication, then we can just continue it, and that's really how we manage patients medically initially. However, if a patient's requiring 2 or more anti-anginal medications, we want to consider invasive coronary angiography with a view to intervention if they are having ongoing angina symptoms. As mentioned previously, invasive coronary angiography does carry a risk. However, if patients do have ongoing angina symptoms despite medical therapy, then it is a good idea to assess the coronary arteries in case anything can be done percutaneously, or some patients require CABG. If we perform the coronary angiography and coronary intervention can be done, that's basically dilating the coronary arteries and putting in a stent. That can be done at the time, and a patient would need to be on dual antiplatelet therapy before a stent can be put in. However, if a coronary angiography is performed and they have complex coronary disease or 3-vessel disease, including the left main stem, then coronary artery bypass grafting may be the better option. If there is complex disease detected on coronary angiography, the usual practice is to have this discussed in a heart team meeting, which comprises of cardiologists and cardiac surgeons, to discuss the best treatments for the patient. This information is then presented to the patient, and ultimately the patient with their cardiologist will make that decision. So just to summarize, angina pain is usually a chest tightness, usually comes on with exertion, relieved at rest, or GTN spray. There are a number of investigations that can be done. The main investigations are non-invasive, but we do have invasive investigations such as a coronary angiogram. There are a number of medications that can treat angina. We want to treat initially for secondary prevention using aspirin and a statin. However, there are a number of anti-anginal medications that can be used to manage angina. If the medications are not controlling the angina symptoms satisfactorily, then patients can go on to have more invasive investigations with a view to either stenting or bypass surgery. I hope you enjoyed my video, and if you'd like more videos like this, please subscribe and click the notification bell, and you'll be notified of any future videos I make. And thanks again for watching.